Oh, I'll be honest with you. I've been really thinking about it, but I don't know if I'm going to make it. So Eric's going to be out there. But I don't know if I'm going to be there. Are you looking to take something out on me?
No, I was just asking.
Yeah, no. If not, then I'm going to be out for the next one. So I'll either come out for this one or the next one, even if Eric's teaching. Okay, Patrick, 40-year-old male with recent wrist extensor pain. Findings in non-fatiguing weakness, right triceps, right wrist flexors, wrist reflex, biceps tendon. His sensations intact. What does it sound like? What would you think of this when you see this? Give me one differential, one possible etiology.
I'm thinking it's more muscular right now.
Okay. Etiology, muscular. What could be contributing to it?
Uh, Possibly like an overuse.
Progress.
Okay, I'll throw in here then that this individual has not changed their activity level significantly or done anything new. So we'll kind of take out overuse in there. Kristen, what do you think this is? I know you just jumped on, so I'll throw it to you right away, put you in the fire.
Sorry, let me read it real quick. Okay.
40-year-old male with recent wrist extension or wrist extensor tendon pain, finding is non-fatiguing weakness, right triceps, right wrist flexors, wrist reflex in the biceps tendon. Sensation is intact.
And then what's your question? Sorry.
What's one? Really, it's one etiology. What's one? What do you think this is? What's one diagnosis? And then what's one potential cause of this?
I'm gonna go like C7 segmental facilitation.
Oh, look at you. Okay, that would be an etiology. What's your diagnosis?
Do they pick on people or someone's volunteer? Yeah,
I'm not sure.
Diagnosis.
Sorry, I don't know.
This one, the most likely one is you think about your pathoanatomical diagnosis. It gets a little confusing sometimes. That's why it's nice to sort because this is probably somebody who has an extender tendinopathy where you get some irritation of this. But one of the etiologies could then be, what you said, C7 facilitation. Only later. Probably the most common one would be that extender tendinopathy. That's kind of where sometimes we get a little buggered up between the differential diagnosis, which you think about in terms of our pathoanatomical, and then what are the contributing etiologies? So like a segmental facilitation would be that, which is a pretty good guess since it's sitting right here below the question that I asked. So what in here would differentiate this from like a concept of segmental facilitation, Kristen, from a radiculopathy?
Would radiculopathy not have, would it have like hyporeflexia versus wrist reflex? More fatiguing weakness of triceps and wrist flexors. And then with a radiculopathy, you could have some dermatomal changes or sensation changes.
Yeah. And let's say this person was across it. So the dermatome changes, dermatome changes can be plus or minus. Have you ever heard of a skin scratch test, Kristen?
Yeah, I think that was in the in one of the videos.
Yeah. it's a cool one, and you'll do it when you get out there, where you actually scratch the back of the neck.
Isn't that
And
like
which
you
is
do it at the segment
yes,
that
yeah.
involved?
It's one of the weirder things in how it works, because we're used to seeing reflexes and we're used to seeing muscle tests, but the skin scratch test, to see an area that stays white and blanched while you get the red line around it. It's kind of an interesting finding that you'll see this. Not always consistent, but it's funny how much you will see it.
So it
So
stays white at the segment?
yeah. And you
Okay.
have changes in vasomotor tone at that segment. You see this now. The research on segmental facilitation is scant. Okay, there's not much out there. This is highly debated in circles. Does it not exist? Where is it? It really came out of some osteopathic, medical model a number of years, I mean, almost 70 years ago when they looked at it. This is something when you look in the literature, you're not going to see a lot to support it out there. But when you get into class and you see it, you're going to see how Eric uses it, and you're going to be able to pick it up fairly quickly in people as we see this. And it'll have this you'll have this presentation. And you'll see it a lot in like tendinopathy. It could be a shoulder dysfunction. So this patient could easily be somebody who had, here I have a patient with elbow extensor tendon pain, where he's overusing his extensor tendons, which is, relatively a C6 region if you think about it. I'm sorry. But what you have is you have a C7 facilitation because he's trying to generate power through the wrist when he should probably be doing it through the shoulder. It's kind of what I'll see in this one. So because it's impairing shoulder function, this person doing a lifting or another technique transfers a little bit to the elbow, overuse the tendon. But I may see that this is a C7 facilitation. So you'll find these facilitations, throughout your patients. What's good about me is I'm going to say I see a lot in upper extremity patients. Eric tends to talk about it, seeing it more in lower extremity patients. So it's kind of a good blend. I gave you probably more upper extremity cases where Eric will kind of go over the lower extremity precinct. So Jim's video here.
Dave, real quick, back to radiculopathy.
Yes.
Would you say cervical radiculopathy could be a diagnosis and the etiology for that could be like a lateral stenosis?
Yes, correct.
Okay.
Be a lateral stenosis, etiology could be disc herniation, you could, yeah. So it's a good way to think about it, because it's easy to get buggered up because you're often trying to think of, okay, we'll go one level down to the etiology when really come back to the pathoanatomical as we're talking about it. So you're explaining it, as an individual, I have a pathoanatomical problem. And now what I want to treat, my treatment is going to be lots of times in the etiologies. Okay, what's making this happen? Why do I have this tendon problem? Is it truly that I have acute overuse and breakdown in this tendon, or do I have some other contributory factor? Is it a lateral stenosis in this case that is creating compression of the C6 nerve? And that's what's creating some of this stuff, which would be kind of, where you talk about more radiculopathy model or an AXT model, or it could be segmentally referred. So if we're looking at referred pain, I have lateral elbow pain, but it could be from C7. Things to think about with this, let me blow it up a little bit here. Jim talks about, let's talk about the segmental facilitation is prolonged aberrant input through the spinal segment. And they'll talk about, probably nociception because of aberrant, mechanoreceptors, and how the system facilitates. So they'll talk about you could have nociceptive or low grade irritation coming in, say in this case, anywhere in like the C7 region, from the muscles in C7, the joint, or the dermatome. I also think you can see it with C7 irritation in the neck. And sometimes you'll get this where, you'll have a C7 irritation, that segment, and it'll facilitate that C7 segment. So I'll see this frequently, like CrossFitters, I'll pick it up in very classically, they'll be weak to their overhead, lifts will be impaired because this exact pattern that I just talked about. We'll see. And then mobilize or manipulate the neck, and I can take them back to 5 out of 5 strains. And again, brisk reflex goes down, or its output goes up. So you'll see this model of facilitation in patients, and we'll go over it. I wouldn't quite call it radiculopathy light. This is somewhere I think that lives within the sensitization model, and I probably have to put it in more of the, it's in the central sensitization thing. So in my mind, and this is purely my mind, when I look at this and how I categorize it, I would put it in that family. So it is different in its presentation from your classic neural windup and increased sensitivity, because here you're seeing basically a ramp up at that segment versus a hyperesthesia or temporal summation that may happen. But again, classic hallmarks of this are going to be in hypertonicity, when it's the gamma afferent. So you do the reflex, it's brisk. It's not spastic. But when you do left and right, you'll notice that reflex will be more brisk than the other side. So I definitely need to check both sides when I do this. Do I have a brisk reflex? If you're looking at non-fatiguing weakness, it's that idea that, okay, this isn't a fatigual weakness where I'm running out of neurotransmitter. Scratch reflex. Tropedema, I don't see this as much, but this is just because you get this sympathetic change, not only when you do the scratch test to the neck, but you can see some skin changes in the local distribution in the arm. And the old classic one would be the teal to orange syndrome, where they talk about it's almost like they get the goosebumps, as it were, in that segment. And in chronic cases, they'll talk about loss of hair. If it's been going on long enough, you'll see that there'll be a loss of hair in that segment as well. And with this, you have a bit of tone in the muscle at rest, but when you go to test it, then the muscle's weak. So you have this kind of mild, low-grade up ramp of the muscle, but then when you do a muscle test, it's got fatigue and weakness. And we've seen versions of this everywhere, guarding reflexes. So we'll have to separate this out from some of the classic guarding reflexes, but this facilitation can certainly live with any patient who has pain around a joint. There tends to be some hypertonicity and guarding reflex in the muscles around there. And that can contribute to this facilitation, in which case mobilize the spine, and all of a sudden you see decreased tone in the. Yeah. You look at needling world, Chan Gunn was one of the ones that put out like a system for needling in pain management guy, Canada, looked at the model of segmental facilitation, saw that he was needling, doing EMG studies on people. They were coming back saying they got better after EMG, figured he's needling segmentally. And he looked at this segmental facilitation model and kind of look at the history of where we are. The Kineticore model came from the Chan Gunn model in Canada. Ado was out in Colorado, kind of brought this back from Canada when he trained up there. He was at the right time started Kineticore, which is then involved by EIM, and now they rebranded it under EIM and probably changed it up since I last paid attention. But if here's one little bit of history lesson of kind of looking at segmental facilitation, this concept of the nerve and disc, it's just kind of an interesting little history where it comes. Questions on this?
No, just something to add, Dave. I see this a lot. Like we were talking about last week, my OT is really good at identifying folks who come in presenting exactly like this. So she thinks it's a lateral epi. She treats it like a lateral epi and they're not getting better. They might get like short-term relief. And then she sends them my way. And from like a cervical screening global, they don't really present with cervical pain. They don't have cervical pain, but as soon as I start digging into like side glides or get more into like the uncovertebral joint area, that's where this is like really, really obvious that something's going on.
Yeah. I mean, you probably can't see because the clarity of my screen. There's a little tear in my eye right now. I'm so happy for you. Because you're spot on.
Dave, can I clarify on the weakness part?
Okay, my tear just went
Eric
away.
describes it as a velocity dependent, almost what he says, a braking
Yes.
weakness. Does that does that resonate with this type of weakness?
Yes, yeah, I think it's almost I think this one is easier to find. I think the braking weakness you'll also see as well. But if you may not find it here, it's also good to check that. I think it's just another layer on that, where they're not able to generate sufficient tone immediately on the quick stretch. That is not as widely talked about. That's like a little subclassification within this system. Quick and efficient, and you can see it, and I think you're going to see the same response. So you may want to check as you're testing it. Okay, non-fatiguing weakness. I think I see non-fatiguing weakness. Let me do a brisk reflex or brisk stretch, see if I see it. Because then what I'm going to do is I'm going to treat it right away. And then I'm going to retest it. Mainly because I look really, really cool if I can fix it in 10 seconds or less. So that's really more about me. But then I get buy-in, and then I can kind of get them to kind of do more and kind of get them where they need to be. So I will use this absolutely as a party trick buy-in. Because the one thing I need to do is build rapport with the patient, and then they need to have confidence in my ability. So this is a really good way, like, to build that patient rapport, but also once they see that you kind of know what you're talking about, and you've seen, it's like what Teresa's doing. They see Teresa do this, and she makes a difference that quickly. You know, again, there's immediate buy-in to Teresa, so they will kind of follow along with her and stay with her a bit more, I'm guessing. Is that right, Teresa? Or does your personality get in the way?
Yes, it is. They like don't want to see anyone else and think I've done something magical, like you said, but all I did was just chase it proximally.
Yeah. Yeah, really, it's an interesting party trick. Again, as you do this, you know, I'll also, if you don't want to have to keep them forever, preface it, this is my true value to you. I'm going to get you here, and you're going to do well with the OT. I'm going to look at this one thing and clean this up as you need, you know, but you won't need, you know, once I get this done, you should be pretty good, and their plan will be good for you. So many times on your end, if you don't want them to fall in love with you and stay with you, it's preferencing kind of that. It'll be difficult. It's difficult, but you're going to want to do that eventually because you need to put these people out there so everyone doesn't end up on your schedule. But you can become the go-to for these types of things. We can chat about that more as progresses on in 7 and 8. I think it's worth going over how to spread the love. So it's great to fill yourself, but it's also good if you can fill yourself and then push to others. And then they'll be more interested in what you're doing and want to learn from you. So yeah, segmental facilitation, super interesting. Not much out there. To read online, like before I do these Zooms, I go out and I look out and see what's published, what's out there recently. Still, this is pretty battered as a concept and pretty old, but I see it so much. And now that we've seen this cervical spine, I see exactly what Teresa saw, which is choosing an oncovertebral joint, where I'll go in there and I'll do the lateral glide, the translation, treat the onco, I'll mob it, and it opens this system up. So that was super cool. Teresa.
I have a quick question, Dave.
Mhm.
So when you were saying like the C7 like segmental facilitation was like the etiology, so then would the diagnosis be like a mechanical dysfunction in an oncovertebral joint or facet joint or something like that?
Good question. Like at that point, it becomes chicken or the egg. Like if we're doing this like a practical or somebody, one, Eric and I wouldn't ding you because you're on the right track and you're getting it. But I would say that this person has developed probably an extensor tendinopathy from the breakdown of that. Now, if I treat this immediately and now all of a sudden their pain is gone, then I know there's a central component to it. Maybe it's not a tendinopathy. Sometimes I'll explain it to the patient, like you're getting a tendinopathy because of this is breaking down your system. And if I correct this, then all of a sudden you'll get less of it. But now I may need to do something in their neck, or I'll look for a neck mobility program or self-treatment. So if they go to lift or load things, that they can readdress it. So sometimes this will be purely in the neck. And you address this, and that's more that referred somatic pain versus that person because they've had a change in their aberrant pattern. They now have a tendinopathy. Tendinopathy model would be that person, let's say they're doing an overhead lift with a free weight or a bar. As they go to raise that weight above their head, if they aren't getting sufficient output from their E7 muscle group in the shoulder girdle, and what they try to do is maybe they're trying to pull it with the wrist. They don't get adequate momentum. So they'll maybe try and pull hard with the wrist. Those extensors aren't well built for that lifting technique. So as soon as I start moving that load over to a different group, I start beating it up. So like one where I classically see would be that person beats that up because they have a C7 weakness. They go to lock out their elbow overhead. Triceps isn't the same. They often look asymmetric. So I'll see that asymmetry in them as they move. And that shifting creates the tendinopathy. So when I look at somebody, I think, you know, this is essentially driven. If I treat the central one, are they better? That's really easy to test and retest because I mobilize the oncovertebral joint. They get better. That referred somatic pain goes down. I have a good answer. Then I still need to retrain some patterning. But I may be that I treat the neck, I correct their strength. Now that tendinopathy has to unwind, I have to make sure that they don't go back to that. They had it. And it's kind of a long answer. That's kind of where I can use that test retest model in this. And sometimes you may be unsure. And it's like, okay, well, I know I can mobilize the neck. Let me mobilize the neck, restore the strength, and see where the dust settles. But those people will generally get better very fast if it is that segment. They'll do much better faster. I put in here some other things. I just put down some notes. And this is me playing with just different things. I look at ChatGPT as some other resources. ChatGPT is nice, but it gives you a glossy form of it. It doesn't give you the complete discussion of point counterpoint. Nice point counterpoints out there, but I just included that. I'll kick this all over to you when we're done. So 18-year-old female club lacrosse player with peroneal tendinopathy, ankle sprain 5 months prior, presents with weak inversion, eversion dorsiflexion, calf raise. She can do it 20 times, no impairment. Reflexes are intact. Kevin, buddy, what you got? Kevin, chew faster.
Bear with me. I'm a little behind on you here. Can you say the case again for me, please?
18-year-old female lacrosse player, peroneal tendinopathy, center of the diagnosis. History of lateral ankle sprain 5 months prior. She presents weak inversion, eversion, dorsiflexion. Calf raise is 20 times, no impairment. Reflexes intact. What have you got? Don't have anything. Rely on your ability to read.
I'd look at the lumbar spine L5 S1 area, see what I find.
What's your diagnosis?
It might be a segmental inhibition.
Now, what's your pathoanatomical diagnosis?
Well, she's got eversion weakness, and so her peroneals are overworking not only to control lateral movement, but also plantar flexion. They're secondary helper muscles for plantar flexion.
Good.
We found weakness with that too.
Yeah,
So yeah,
you'd be given kind of the differential, barring that's not misdiagnosed. But then your etiology would be then lumbar.
correct.
Does this cross over multiple levels, or is this all one segmental level?
Sounds like multiple to me. I look at. Sounds like L5 S1.
We have multiple planes that are showing weakness when we test it. The reason plantar flexion is in there, because if you test it isometrically, just it's seated, then you're probably going to be fine. Toe raise is fine, which is good, but that's a big neural drive and output. Commonly see around an ankle after this is reflex inhibition. Again, lumbar spine could be another etiology, absolutely, where I could have the segmental facilitation, have lumbar spine involved in it. Certainly, I could have anything going on there, but when I see multiple levels being weak around a joint, that's at Jim's concept of you're looking at reflex inhibition that occurs, muscle strain and true. And his thought process that it's an adequate proprioception, possibly of excessive proprioception. There's always, something happening outside these neurological tissues that if I have reflex inhibition, that okay, there's changes in the proprioceptive input through the joint. Let's say I tear the ligaments in my ankle, and now I'm not getting that proprioceptive input from the stretch of the ankle ligaments and structures, or the peroneus is irritated or been told. That aberrant input is going to create reflex inhibition, multiple planes around the joint. So where segmental facilitation may be limited to a segment or a neurological segment, reflex inhibition is going to be more around the joint in a larger area. And again, he's talking about, you see hypotonicity, you're going to see breaking weakness. And when we look at putting proprioceptive input, what you do here would be proprioceptive input through the joint. So what I might do here is it may be vibrating or doing a wobble to the joint segment. And does the strength change if I do a jerky mob and oscillation to the joint versus the spinal segment? So in Kevin's case, Kevin, what would you do? Would you go up there and do mobilize? You're thinking this is an L4 or L5. You go up there, would you mobilize the segment or put jerky mobilizations because you found the multifidi inhibited, like your own poor multifidi? What would you do?
No, I mean with the information, the makes sense. Anything surrounding the joint with multiple ankle sprains, I would probably try wobbling the ankle first and then retest. And then if I didn't see what I thought I should, then I might go to lumbar spine.
Yeah, and I'm completely okay with that. I will, like, if I see multiple joints here, I'll treat maybe the ankle first. If I think it's more spinal and I'm just getting read, I think, hey, this is more segmental for much move and she's moving in a funny way where they're loading into her lumbar spine, then I might start with the spine. Generally, if I find somebody where I find the pattern is segmental, I'll go up and look at the spine first. I'm seeing an ankle sprain like this, and I get inhibition in multiple planes. On this one, I would treat the ankle first. I don't get what I want from the ankle, then I would not be reluctant to then go up and look at the spine. But I would differentiate between these patterns, being this is non-segmental or multi-segmental. I'd move between them. Now, reflex inhibition here, I think it's good to expand on it because this is a good idea of concept of reflex inhibition. This can be conducted, and this is mostly talking at the spinal level, reflex inhibition. But I think what it's also important to talk about is, okay, what they've also looked at is cortical drive and decreased drive. So what happens to lumbar multifidi when we get pain from the disc or the facet joint? Pull my list here.
They
shut
weaken,
down.
atrophy pretty quickly.
Yes. What happens at 3 months?
Probably non-existent. Very poor recruitment patterns, if at all.
Yeah, we're getting poor recruitment pattern. Why does that persist long after the pain is gone? Why does this subacute phase happen?
Well, I consider kind of that neural loop. Basically, it's getting an aberrant input.
Yeah.
And so that recruitment pattern, as long as it's impaired, it's going to continue to, those muscles continue to weaken. It's just a downhill slide from there, unless it's corrected, unless it's addressed.
Yeah, that's why I like to think of it kind of similar to the ankle model. And you see when you look at the lumbar spine, and we had this in like module 1 where you saw like curve where you showed the acute, subacute, and chronic phase of lower back pain and atrophy of the multifidi. And the other influence in there would be reflex inhibition segmentally, but there's also a decrease in like cortical drive or inhibition of that segment. So you see that the brain map will actually change a bit over time. We have reflex inhibition, but I think we also need to, in some ways, take into account, again, what changes centrally in our drive mechanism. And this is being better researched. And they've looked at this with lumbar pain, the model we just talked about. I've seen it recently in an article on elbow tendinopathy, where they looked at the changes in the cortical map with chronic tendinopathy, and after tendinopathy, that map has changed, and maybe their patterning and recruitment distribution remains altered. I know I've seen it with Achilles tendinopathy, that the cortical brain map changes, and it's like transcranial magnetic stim is what they use to look at the excitability and inhibitory stimulus within the brain. And they've mapped these areas out to see that, hey, these patterns change. So reflex inhibition, it exists, I think, as segmentally what we're looking at, so I can wobble the thing and I get the input. But in my mind, I like to take it a step further and start to look at some of that research that's cool on what's going on in my cortex. And helps with that is that feed-forward mechanism of using a metronome with timing with ankle rehabilitation, so that I have to keep pace with a metronome. I am not self-selecting my time. What I'm finding is my comfort zone. Now, to rehab some of these patients, you need that feed-forward cortical thing, thinking, oh, I got to go a little bit faster. I can do this at a tempo that I'm accustomed to. But kind of all hands on deck. So not really included as presentation, but area cortical drive is interesting. And I think we can kind of keep our head on it. I think it fits in well with, it's different than when we talk about central sensitization and brain pathways, but it's nice to understand that this is kind of what we're seeing in individuals. Any questions there? Anything that Amy would like to add on reflex inhibition patient you've seen? No. Abby, you ever seen an ankle sprain before? Don't tell me you're in a shoulder clinic.
Yes, I've seen an ankle sprain before.
Cool. What's the general things we do in rehab for an ankle sprain? What's the kind of the base package things we do?
I do a lot. I mean, it obviously depends on the age. I see a lot more athletes in my clinic. So, I mean, for HEP, I do a lot of just like basic ankle exercises that they can do at home that they can like stay in because high schoolers kind of suck. But in the clinic, I do a lot more like proprioceptive,
Mhm.
trying to like pay attention
Mhm.
more when it comes to, like cutting, turning, things like that after their pain has gone down. Obviously, I'm not going to cut and turn until like their pain has subsided a little bit. But a lot of like balance and proprioception is what I do usually.
Yeah, and that's where we're addressing this reflex inhibition. It's the timing and firing pattern. It's the reflex inhibition at the segment because of the pain or the nociception that was coming through the tissues. So for to pain inhibition, so left over after that is the reflex inhibition. Right, the system remains down ramped, and that other layer on it is that feed forward. Okay, do I get cortical inhibition? And when we think about that too, like with the cortical side of it is increased incidence of ACL tears and lower extremity injuries after ankle sprains. I think it's that 6-month window that they've studied. I have to look at the literature again, see if it's been updated. But it's because that cortical map and that recruitment pattern has been changed, ankle pain. And that's why you're doing proprioceptive jumps. It's kind of like, this is kind of validating what you do more than kind of trying to argue with it per se. Just understanding it a little bit deeper sometimes. And okay, where can I maybe get a little bit more out of this person if I understand reflex inhibition and cortical drive? And am I treating both of these buckets within that ankle sprain scenario? Which sounds like you are, which is good. So I don't need to beat you up too much.
Dave, I have a quick question.
Shoot.
I'm just thinking in terms of like rehabilitation from reflex inhibition to segmental dysfunction. If we could stick to the ankle since we just talked about
Sure.
what we could do with like reflex inhibition. Let's say it's the opposite, segmental dysfunction, and you find that like wobbling improves strength in a region. Like, what are you doing to reinforce that within like the clinic? Differently.
Oh, so let's say this is coming from the lumbar spine. I
Correct.
think this is segmental coming from the lumbar spine. Yeah, now I know I have a lumbar component to it. I'm going to go in and, balance exercises are good for multifidi. Me personally, and again, you may have a different model and it's just as valid as mine, is, I would look at, okay, I'm going to incorporate a little bit of the motor control work first. Take some of Paul Hodges' work. And then I may blend in some, Stuart McGill's work on, okay, now that I get you up, can you set the entire system? Get the entire system to go and set the floor and do this. And then as I get into more dynamic and balance work, I'm going to make sure they take that abdominal toning exercise that they learned on the mat, they incorporate that prior to single leg loading or single leg jumping, moving into the ankle rehabilitation. But with that person, I'm going to subcategorize them and make a bucket of maybe 7 to 10 minutes of prep motor control lumbar work, and then go into the ankle work.
Okay, that makes sense. Thank you.
And I'll do that with a ton of runners. I'll do that with most athletes I see, is that, okay, making sure that they can set the proximal system as they load the distal system. Again, we did it in class too. It's really easy. It's like you find that if you just kind of induce a little bit of abdominal tone, like bathing suit pitcher tone, you're gonna find if you're jumping up and down on your ankles, that it'll get your Achilles tendon stiffens a great deal. You transfer energy much more efficiently with that little bit of bathing suit tone, as it were, versus a normal relaxed tone. So
Thank
I make
you.
sure any of my ankle athletes, they need to understand that reflexive pattern of the core, that stabilization pattern. It's very, very important in the functional ankle. So now it's a real good question. It's a fun topic to talk about. All right, John, who do you want me to ask the question to next? Pick somebody from the group. Like Lord of the Flies now, where I turn you against each other.
You're gonna make me do this?
Yeah, I'm gonna make you do this.
Well, I'm gonna go based on who you like to pick on, Dave. So let's say Chan.
Oh, thank you.
Thank you so
Damn it.
much.
That's like a late Christmas gift. How you been? Okay, Dan, 35-year-old female, right lateral elbow pain, MD diagnosed extensor tendinopathy. No change in activity, unfamiliar use, metabolic conditions. So what's the diagnosis, which is basically given to you? And what etiology would cause this?
You say metabolic conditions, so just inflammation somewhere? either disease
inflammation,
or
like nerve disease, anything that would give you this condition that's okay, you've had something funky change. You know, it's not a virus, it's not anything of that nature. New medication.
In the restroom, it's right down there.
I mean, we're just saying basically what you axoplasmic flow is changed. What are you asking?
Yeah. So what would change axoplasmic flow? Good answer, Chan. I can say that much.
You know, at that age, at 35, I'm looking at, you know, worried about, do they have a 35-year-old female muscular dystrophy, something like that? Or you? Multiple sclerosis, excuse me.
Her eyes are tracking fine. She's not tripping or falling. I would put it, maybe not metabolic condition, but I would put that in that central thing I was trying to rule out.
Okay. All right. Tell me your question again.
Okay, I'm gonna give you this. We kind of get a sense on she has extensor tendinopathy.
Yeah.
You know, you guys can read in Mississippi, so you're probably guessing it's an axoplasmic flow issue.
Well, that's what, yeah. Based upon the other two previous questions.
Yep. Yeah. So what would cause a disruption in axoplasmic flow?
But she hadn't, nothing has changed with her.
Yeah. Yeah. I mean, that's why the metabolic thing would take out, because a virus could do it.
Yeah.
You know, you're right. You're talking about there's other metabolic conditions can do it. And when I say axoplasmic flow, it's an older term. I'm gonna throw in the term, and Jim will have a reason why I'm wrong, but I think I'm right. We're talking more about axoplasmic transport of nutrients would be the better term. And how this gets disrupted. So what could do this? What would be the most likely thing to do it?
I mean, if she hasn't been hit on her elbow, hadn't done any nerve compression.
Yes. So that's the real question. What would compress a nerve to give her this condition? Where?
And like I said, if she hasn't hit it or anything, and the only thing. I mean, you can get the elbow pain as far as with the supinator impingement as far as the nerve, but that's.
You just realize that's probably a little distal, right?
Excuse me, the pronator. Excuse me.
Mm-hmm. Yeah, but that's probably a little distal for a lateral extensor lateral elbow pain. Could be more forearm, anterior, mid-arm, that type of syndrome. I think more centrally. What's the most likely thing to give me maybe an axoplasmic flow disruption? That's
more sort of like
spine.
a lateral stenosis or lateral impingement.
Exactly. Start close. Something like that may do it. I hate this term. I like the idea of you're looking at a mechanical disruption of this system, then you think of like the small lateral crush. What would disrupt it? It has to be a small compression. So lateral stenosis, posterior lateral disc, osteophyte, something along those lines could do this. Or some
but
other.
You're not going to see an osteophyte really on a 35-year-old, are you?
This is not an uncommon to see disc degenerative disease in a 35-year-old female. It could be instability, it could be a posterior lateral disc. Soft lesions in her, less likely articular, unless she's got like Ehlers-Danlos or something funky going on. But with the most common thing here, maybe a soft disc lesion. And you got this low-grade compressive, so it's almost like radiculopathy light. You have just enough to irritate the flow or nutrient transport through the nerve, but not enough to potentially give you, hard neural signs. And what they'll also talk about with this chronically over time is that this model, again, I haven't seen it well supported in literature, but the idea is that if you disrupt the nutrient flow through the nerve, then what happens over time is does the end plate organ break down, and then you develop a tendinopathy because of the end plate organ breaking down. Versus, let's say you have this axoplasmic flow disruption, you're not really picking it up as a radiculopathy. They do have fatigable, they're going to have fatigable weakness. They're negative, positive, depending on positions. Positive local wobble improves it because that neural input. So this person, you're going to kind of think, okay, is this more of a radiculopathy? But then you wobble the neck or manipulate the joint and the symptoms go away. it's probably somewhat this disruption that you may see. Why that idea of maybe radiculopathy light there.
So Dave, are you saying that asthmatic whatever flow is just a compressed nerve? Like, I'm so confused.
You can think of this axoplasmic transport is the motion of nutrients retrograde and antigrade through a nerve. Where you'll hear about it most is like a herpes virus moves through the nerve. That is a classic example of something that moves, like something noxious that moves through ectoplasmic transport. And I put a couple of the notes in here that I'll send over to talk about that. To us, what we're probably looking at is some type of disruption or compression of the nerve, which may not raise to the level of, a pure radiculopathy presentation. Is enough to disrupt this flow of nutrients, into and out of the mitochondria, the lipids, the intercellular messengers. And then the further model is that this disruption of nutrient flow through the nerve may be enough to disrupt the health of the end plate organ and how it transmits signal to the muscle when you get breakdown of the tendon. That is the tendinopathy model, taking axoplasmic flow or transport to the point where, okay, I've disrupted the flow of nutrients and key material that I need. End organ is no longer getting sufficient amounts, so I get end organ breakdown and tendinopathy. Where we'll pick it up is this kind of almost radiculopathy-like presentation. So it's a tricky one. It's a bit of a stretch, but it's kind of good to kind of get a sense of it, because you see a fair amount of people like this. Some people be facilitated. Some people may have these kind of, mild problems or tractions in nerves or torsions. So I think what it is like, if we see anybody with any type of maybe peripheral neural compression, I mean, think about it, a carpal tunnel syndrome, would cause this, and probably in advance of you getting, neuropathic pain or paresthesias, because you're going to have a disruption in axoplasmic flow to that structure.
Dave, is there something specific you would do for a patient presenting like this, or is this just purely educational information piece of the pie that could be contributing to someone's diagnosis and therefore may or may not change what you do? Or is there something specific you do for these patients when you are suspecting this is at play?
With this patient, let's say this patient has an abducted ulna, and that abducted ulna, like, I'm going to change the lateral. I'm going to change this to this patient has basically, pins and needles and hypoesthesia and their hypothenar eminence and half of their fourth finger. The abducted ulna, because the ulna head shifting into the ulnar nerve will cause this sometimes. And you can manipulate the abducted ulna, and you'll see these symptoms resolve rather quickly. So if it's a compressed neuropathy, then I expect them to heal in 4 to 8 weeks, or 6 weeks being an average. But with this, what I end up seeing is that I take the pressure off of the nerve, flow restores, and they get better faster. So you will see this in things. You'll see this sometimes where, okay, I mobilize the neck and it improves this as well. So you can see this as just variations where sometimes a segment can become facilitated or slightly irritated. Other times, if we get loss of axonoplasmic flow, we can do this. It's harder to prove that, okay, I made this tendinopathy from this, but what we're going to learn here is we're going to follow the nerve when we have one of these problems and see, okay, what do I have going up the chain? What are the other muscles in this segment look like? What does the spinal segment look like? What may be putting stress on it? And what's the mobility condition of the segment? That's really kind of your true takeaway. And again, the concept of ectoplasmic flow, it is nice to know that, yeah, this is the system, this is how it moves retrograde. Not a ton written on it taken this far, but I think you're going to look at somebody the next 6 months and go, yeah, wow, this person it's like, mild it's like radiculopathy light. I have neural irritation. So think about some of the things, if we look at the work of, Shacklock and other people with neurodynamics, that's kind of the world that they're talking about in. that will see, these things kind of occur with that, with this neural compression or neural tension, you'll have some of these components. So ectoplasmic flow disruption will be one of the things that can occur if you're looking at neurodynamics. It's heavy, and it's if you don't have your head completely wrapped around it now, it's nice to have a little concept or growing concept of this prior to going into the weekend, because that way you're not trying to absorb all these manual techniques and then concepts. So getting a sense of, okay, where these three things are, I can start to slowly work through them, move around, is plenty. And every now and then, just like your head gets put in a blender and they all spin and you confuse them, and that's okay. Okay, because you'll be able to kind of cleanly kind of sort through them just with your manual muscle test, reflex testing, segmental exam, and then looking at the cervical spine to evaluate the motion state of the cervical spine. From there, if it's screaming like, okay, I have a compressive neuropathy, let's say a pronator teres syndrome, and alluded to, okay, with that pattern, I expect to have pain and irritation with resistant test of pronator and palpation should be positive. And that would give me that indication of, okay, I have a neural compression and here's the site of it. Jim's next presentation, we'll get into this a little bit, and this one is probably a little lot easier to swallow, given what we just did, is that, Jim talks about types of weakness. And, again, he kind of divides it out here in a little different way, which is kind of nice, actually, where you have neurological. We talked about there's radiculopathy, there's neuropathy, axoplasmic flow compromise, which is, again, kind of like radiculopathy light, where we have a decreased flow of nutrients to the end organ and through the nerve, but not necessarily disruption of speed of signal. And then there's, neurological, there's centrally driven weakness by cortical inhibition, cortical pathways, neural disruption, stroke. Neurophysiological is the idea of you have pain inhibition, reflex inhibition, and segmental facilitation. And within there, I would actually probably put cortical drive down in neurophysiological. And keep central as being something that's more of a pathological process. Structural weakness goes back into that classic model, which is okay, I have a, macrotraumatic tear, a large tear of a tendon or muscle, or a chronic degenerative tear that is slowly over time broken. Within those variations, we kind of can move through these. So as you look at these, it's like, okay, over time, you're going to be like, okay, I can kind of move through all these. The most confusing one is probably going to be the AXT fast flow compromise one. It's just, if I were to look at them all. The other ones are a little bit easier to sort through. Is that a fair statement?
Yes.
So that idea of you get to that point, you're like, oh, I completely forget what, segmental AXT flow is. I then to go back to my mind and think, okay, radiculopathy. I have neural compression or disruption through the nerve, where the other things are more like the signal facilitation is ramping, more like a sensitization or sensitization. They should probably, though I differ in my opinion from Jim on this, I would put the sensitizations probably maybe in the neurophysiological. I mean, there's an argument you can put them in neurological. If anyone has a strong opinion on that, please feel free to give it. Causes of weakness. So this is super, super easy to root through, isn't it? Okay, Jim has this in his presentation. Good one to go through, packed with details. But, let's just think about just ways of thinking about weakness. Classic model, we think of weak like a weak muscle. I have somebody lie on their side, check their hip abductors, I push down, and they're weak. Ah, you got weak hip abductors, and you have weak glutes. Thinking deconditioning. Well, it's always a little bit more complicated than that. And it gets more complicated in maybe this diagram. But classic deconditioning. I'm looking at somebody who's been put in a cast, somebody who hasn't done a lot. There's been a reason why they haven't metabolically used a muscle or system, and now they're trying to use it, or they've been taken around. That's your classic deconditioning model that we look at. Structural, as we move here to the left, He's going to talk about, AXT flow and degeneration of the segment because of a decreased nutrients to the end organ. System breaks down because I have decreased, nutrients to the end organ. So neuromuscular junction, tendon breakdown because I'm getting decreased. There, I will also talk about there is the decompression model. Again, structural rupture of a tendon or muscle will certainly give us weaknest. And neurological atrophy, that would be the, myasthenia gravis, I believe used by AXT, but your other neurological atrophies, you could have, is it MS, or you're looking at something going on. So you have these structural kind of breakdowns that go on. Your neurophysiological is kind of the world that we treat in a lot here, where it's okay, I have neurophysiological, I have pain and nociception coming from tissue, and I want to reduce the driver of the nociception, whether it's a movement, mechanical stressor that's on it. There's management of inflammatory mediators that are creating that and creating that neuro input to create that pain inhibition weakness. Segmental facilitation, we talked about, there's maybe nociception coming in somewhere along that pathway, as far as even up at the spinal segment, that's driving this pain. And do I need to kind of look at weakness as being driven from basically this segmental reflex that occurs? Reflex inhibition, potentially occurring around the joint or a guarding mechanism to protect an injured joint. Certainly going to get it with, if we went back up to structural with a rupture of a tendon or muscle, there's going to be some reflex inhibition and probably also some upramping neural tone. And then again, here we have, we're talking AXT compromise. Fast flow would be more like probably neurotransmitter flow would be the fast flow. Getting that fatigue and weakness, or disruption of the fast flow system. You're not able to replenish neurotransmitter. Model looking at neurophysiological. Neurological weakness, again, good. We got that one straightforward. We have peripheral neuropathy, which is again, certainly in the periphery. We have some type of disease mechanism within the neural system. And your classic kind of radiculopathy or neural compression, whether it's, in the 35-year-old, or probably thinking, like Dan mentions, probably a soft disc lesion. Okay, if I made him a 62-year-old, we're probably looking at a stenosis and a hard disc. People doing set joint, joints per. Think of that nature going on. Okay, before I get into this one, because there's 3 minutes. Any questions or clarity, anything you kind of picked up on this, or having an aha moment from today, like, oh, okay, this makes more sense now, and this is why I didn't. So if anything, you can kind of give me something that you may want to get clarified, or give me something that makes more sense before we started. Totally screwed you up. Keep it to yourself. Anyone before I start calling on people?
Dave, I'm kind of thinking with at least like what leads up to a tendinopathy, that definitely makes a lot more sense, because I didn't really get like I understand like what segmental facilitation, reflex inhibition is, like I get it, but like how that relates to what you might see in a patient presentation, that makes a lot more sense now. So like why they have the tendinopathy or whatever it is kind of being driven by, or could be driven by, something coming from the neck or the local joint. So like when you eval someone, it's like, okay, like you do, your usual hypothetical abduction stuff. Okay, you have a tendinopathy. Then you kind of have to figure out, okay, like, overuse, or is it an abducted ulna, or is there something else coming up from the neck? So that's kind of what makes more sense to me.
Yeah, and that's really what this process kind of starts to get to think about. It's like, yeah, I have this extensor tendinopathy. How can I start to tease through it? If we're looking at segmental facilitation, then we're looking at, okay, do I have segmental influence? I'm finding it in the C7 or C6 distribution. If we're looking at the upper extremity, reflex inhibition, okay, I'm seeing changes all around the elbow. So what proprioceptively around this joint may have changed? There's something damaged, or do I have this now either a spinal reflex, cortical drive? With those two things, I want to think of, okay, treat the segment. If I have a cortical drive issue, then I know, okay, at some point I need some feed forward mechanism to get an increased oomph in the signal to kind of generate that power. That's what they see in Achilles tendinopathy. And even I didn't see, I have to look back at the extensor tendinopathy, but that's where some of that feed forward mechanism, we got to improve the strategy. They'll also see that over time, you'll see changes in the contralateral elbow because of the cortical map change. So it's not always restricted just to that side. you'll get some overflow into the system. And it's a similar process you'll see with central sensitizations and increased pathway and increased pain thresholds. Manipulating the lumbar spine helps with wrist pain. It's like that cortical treatment. So this is where we operate a lot in these different systems. XT stuff is a little tricky, but I think thinking about that a little bit like radiculopathy light, because you're going to look for nerve compressions. We're going to think about that, but to think about that as being a potential contributor. And in my mind, I might just go through something like, okay, where are the spots where this nerve may be getting compressed, and how do we evaluate what that area is doing? As well as in here, just load transfers. And that's more that pain model, understanding how load transfer. We're good. Hope I didn't completely screw everyone up with this.
Dave, I have one last question.
Shoot.
Is Eric gonna have an hour by hour for next weekend?
Yes. Let me see if I have that saved in the folder if it's not up, and I will kick it out.
Okay, I just wanted to put it out there before it's the day before and we have nothing.
No, I'm glad you said something. I'll take a look for it.
Okay, thank you.
Get it out to you. I did look at the hour by hour for module 5, so I'll have that out to you earlier. What I'm going to do with module 5 once that gets rolling is I've already kind of planned out or mapping out the Zoom sessions for that. So what I will kick you out when I kick you that out once after module 4, I'll kick you out hour by hour along with the Zoom session schedule with the links, kind of like what we did these last month. So do all at once.
Yeah, that's been helpful. Thank you.
Yeah, no problem. All right, be good. Take care.